Welcome, everyone. It's wonderful to see this room filled with people, and I understand we have 25 or 30 people online, so it's just a wonderful audience to have at this afternoon's presentation. Yesterday, you've all heard when I sat down beside after the honorary doctorate was bestowed. I sat down beside Professor Pinto, and she leaned over and whispered in my ear, "Now you're one of us." And I had to comment on it when I went to give my acceptance speech, and it's been picked up by the university. And indeed, I do feel a sense of being here with a very special sense of being here with Portuguese colleagues. And as Dr. Nunes said, I hope that this collaboration continues for years to come. So I'm going to spend maybe an hour, a little bit less than that, giving you some more kind of formal thoughts about some of my work. I've been working in palliative care now and doing research for about 35 years. So we're not going to be able to fit in every single thing that I've been up to these last several decades. But this is meant to give you kind of a flavor of the things that I've been doing, the things that I've been thinking about. And of course, if it causes you to think of something or questions, I'm hoping that the second half of our time together here will just be discussion, to talk about whatever, is on your mind or whatever questions might come up during the course of this presentation. And I've called this Dignity in Care, the Human Side of Medicine, which was also the title of not my last book, but my previous book. And it was written I just had an interview with people from the Portuguese press, and they were asking me about this title. And I told them it was written really for anybody who has contact with patients. So this is not just a talk for physicians or just for nurses or social workers or OTs or PTs, physiotherapies, occupational therapy. This is really meant to be a way of approaching care for anyone who has contact with patients. It's a particular way of being with people that can influence their experience. So whether you're the doctor at the back of the clinic or the receptionist at the front of the clinic, you have contact with people. And therefore, you need to understand, I think, these basic principles of what I call dignity in care. So yesterday, of course, was a highlight moment. Being here for an honorary doctorate. I've never gotten an honorary doctorate. I think it could become a habit. Just go around the world. They treat you very well. They feed you very well. In this occasion, they even gave me a ring. I might run out of fingers, I suppose, if there are too many occasions. But this, of course, was also a highlight moment. All of you, well, you'll recognize me. I had a little bit more hair, not that much more. And of course, all of you probably in this room recognize Dame Cicely Saunders. And Dame Saunders was, of course, the founder of the modern hospice movement. And of course, we all stand on the shoulders of giants. And for me, I mean, she was one of those people whose work was, of course, very inspiring. And she kind of created a path that many of us have followed in. So the last time that I spoke in the UK, I gave a talk at King's College. King's College is where Cicely Saunders Institute is now located. I now have the honor of being on the board or the scientific advisory committee for Cicely Saunders Institute. So I gave a talk there, and then I was invited, and again, this is another sort of highlight academic moment. I was invited to give rounds at Oxford University. And this gentleman that I'm standing next to, I mean, he's not as recognizable as Dame Cicely Saunders, but this is Dr. Robert Twycross. I'm seeing some nods of the head. Dr. Robert Twycross, I think he was the first physician to be hired by Dame Cicely when she established St. Christopher's Hospice. And he is responsible for doing some of the early and seminal studies on pain management in chronic cancer pain. So he really changed the world of palliative care and the whole world of pain management globally. So being at King's College, then going to Oxford, it was this sort of a wonderful, very heady experience. And I also learned how appreciative the British can be. Uh, and this kind of raised the bar about what an appreciative audience looks like. That's as funny as I'm going to get, by the way. So if anybody found that even slightly humorous, this is the time to have a laugh. Okay, so moving on to more serious matters. In Canada, there was a very famous, well, certainly in palliative care circles, he was very famous. There was an artist named Robert Pope. We have a wonderful artist here in our audience today. Robert Pope was from Eastern Canada, so the eastern part of our country. And during the course of what turned out to be his a terminal illness, he painted a whole series of wonderful images. This is one of his lesser known images, but I have been using it in my talks lately. When you hear a Canadian palliative care researcher present, oftentimes they will use the works of Robert Pope just because they're so beautiful and evocative. And the reason that I put this one up here is that what you see is somebody who is floating, precariously floating at the water surface. And in my mind, what that then begs the question of is, well, what keeps somebody afloat? How does somebody maintain that kind of buoyancy? And the flip side of that is, what are the forces that threaten to pull somebody under? And when I think about my work and the thread of my work, I mean, they say life doesn't necessarily make sense moving forward. You just follow your nose. But looking back, things do make sense. And I see a thread. And the thread has been to try and understand, these various different forces that sustain or threaten to undermine the will to live, the sense of meaning for somebody who is facing a life-threatening or life-limiting condition. I began looking at some of these issues, especially issues pertaining to dignity. So maybe backing up, I finished my psychiatry training. I mean, being a psychiatrist, I thought I should be studying things that are very typical of psychiatric endeavor: depression, suicidality, anxiety. These are, very kind of bona fide psychiatric issues. And then I discovered that in the Benelux countries, so Holland and in the Netherlands, Switzerland, Belgium, there had been practices ongoing around euthanasia and assisted suicide. Now, this is years and years before, as many of you know, Canada has changed its legislation on medical assistance in dying. That was in 2016. This is like 20, 30 years before that. And oh my God, I feel old when I say that out loud. Somebody told me I look younger than they thought I was. But anyways, I've been at this for a very long time. As I say, when you're younger and you think, well, you say you have 10 years of experience, it makes you sound, well, that's respectable. And then when you say, well, I have 30 years of experience, you say, well, that is a seasoned clinician. There comes a certain number when you start to think, now, if the number is too high, they say, well, why are you still doing this? So I've taken to saying I have 35 plus years. I think, if there ever comes a day when it's been 50 years, someone's going to say, you have to stop. You have to stop doing what you're doing. But this was, the legislation didn't come into effect until 2016. So years before that, and I think this was really in the early 1990s, we came across some of the studies that were coming out of the Benelux countries. Because in Canada, I mean, a wish to die was still something that was hypothetical, at least the wish for a hastened death. The wish to die is an expression of human anguish. So it's not about a piece of legislation. It's not about a social policy. The wish to die is an expression of suffering and anguish. And that has been around as long as humans have had the ability to think and to feel and to contemplate, adversity. So we discovered or turned to the experience of what was happening in these countries because it's not that we were so interested in the policies per se or in hastened death per se. We were interested in the psychology. Why does somebody decide that life is no longer worth living? And the flip side of things we'd looked at, what sustains somebody? Again, that first image. There was a wonderful paper. It was commissioned by the Dutch government by an internist named Paul van der Maas. He was the first author. And he had been commissioned by the Dutch government to explore what they called MDEL, medical decisions to end life. And, as the Dutch government wanted him to, he was able to report, this is the prevalence of euthanasia, and this is the prevalence of physician-assisted suicide. Just to familiarize yourself with definitions, so euthanasia is the injection of a drug by someone that will cause the death of that individual. That's essentially what we have in Canada now. It is essentially a euthanasia program. It is not assisted suicide is actually officially legal, but it's really not practiced. I mean, I don't know of any instance where a physician has given a patient a drug that they can take home and then use at a time of their choosing. So that's how it's played out in Canada. What van der Maas reported is, I think it was something like about 3.5, 3.8% of people, of Dutch patients were dying as a result of a lethal injection, euthanasia, and less than 0.5%, so a smaller minority, were dying as a result of assisted suicide, which, is interesting. It gets you thinking, well, why is there the difference? It seems one is preferred over another. Maybe there's something about, not having to take responsibility for the final act of taking one's life or knowing that somebody else will manage those circumstances. And also, we know that, from studies of suicidality, suicidality also represents a state of ambivalence. Most people who have contemplated suicide don't suicide attempt. And of those who go on to make a suicide attempt, only a small fraction, about 5%, will go on to actually die as a result of those actions. And for the people who made an attempt, 90% don't go on to re-attempt. So, but with a lethal injection, it's harder to exercise ambivalence, which is why, in places like Oregon, there are reports of people who will get a prescription and die with the prescription unused in their medicine cabinet. Again, it's a manifestation of ambivalence about, do I want to be here or not want to be here? Anyways, spent very much too much time talking about that because to me, it's not that interesting, to tell you that. I mean, it's interesting, but as a psychiatrist, as a clinician scientist, it's not what I was really keen on understanding. I wanted to understand the psychology. I wanted to understand what psychological antecedents, the ingredients that bring somebody to decide that I no longer want to be alive. And this is where, for the very first time, I mean, I'd been doing research for many years. This is the very first time that I even occurred to me that dignity would be something, well, I never thought about dignity whatsoever. Now some people accuse me of having a perseverative disorder when it comes to dignity, but this is the first time I thought, this might be interesting. What did we find? What did van der Maas report? He reported, and it was methodologically challenging to get this data. He was interested in now asking the question why. All of these patients have died as a result of a hastened death. So he had to go back to the death record, identified the physician on the death record where cause of death was a hastened death, euthanasia, or physician-assisted suicide. Approached these healthcare providers and then said, okay, what was going on? Why did your patient seek this out? So according to these Dutch physicians, loss of dignity was the most highly cited reason, more so than anything else that these doctors shared with him. Pain alone was not a major player. Okay, so and that's actually playing itself out now, skipping ahead a few decades in Canada. Pain is not the big reason why people seek out medical aid in dying. Pain is part of a constellation of symptoms, yes, more frequent. And then you get some of these things that are hard to understand. They're not definitionally very specific, tiredness of life, whatever that means. Unworthy dying. I mean, I have a good imagination, as most of you would say, okay, I think I sort of get it, but we don't have a good definition. Nor do we have a good definition of what these doctors meant by lost sense of dignity. They weren't told, a priori, here's how I want you to understand dignity. They just said, so why did your patient seek out your assistance with a hastened death? So we looked at this paper, and the thing about research and good research is it answers a question and it raises other questions. That's good enough research. This is definitely good enough research. It answers the question that dignity has something to do with why people might not want to be here, why that person in that image might be pulled under by the undercurrent. But there are a couple of problems with it. One is the source of data. I mean, this is according to physicians of patients who have now died. Not the most methodologically solid way of saying, how can we understand this? And the second problem is we don't know what dignity meant to these doctors. I mean, it just, however they conceived it to, whatever they conceived it to mean, that's simply the result that van der Maas presented. So we said, well, if dignity is worth dying for, dignity is worth studying. And that's really that is the pathway that led to the beginnings of my interest in exploring dignity, which is not the only thing we have studied over the years. I mean, but it's been certainly a part of our program of research. So what's the first thing you do when you're trying to study something new? Well, you go to the literature and you see, is there anything else out there? What you find out at this time is that everybody cites dignity as an issue, but it's a very politicized term, and it's a very nebulous term. It doesn't have any kind of definitional specificity, and people use it to justify their position. So the people, for example, who say, I think euthanasia, assisted suicide is an expression of personal autonomy. This is my body, the patient's body. Ultimately, they get the final say. That is a dignity issue. And it's a very powerful, it continues to be a very powerful and compelling argument that has changed legislation in many places around the world. That's the primary argument, is the autonomy argument. Individual autonomy, not ideas around collective autonomy, which is a separate conversation. If you're on the other side of the political fence, then you say, the Hippocratic Oath, the doctor-patient relationship, the taking of a human life, this isn't compatible with core principles of medicine, therefore it's a violation of dignity. We said, we're not the moral police. We're going to approach this objectively as clinical scientists. We're going to sit down with people all of our patients were in palliative care, which means they had less than 6 months to live. About 80% of them had an end-stage malignancy, and the average age was late 60s, early 70s. When I first started doing this work, I thought people who are very, very old. Now I'm thinking, well, these are middle-aged people, mature people. So that describes the research subject, if you will, or the demographic of the kind of people that I have been studying for my entire career. And we began to explore some of this work on dignity because it hadn't been done. So the first studies that we put out were admittedly simplistic, but simple is fine. I mean, simple can be powerful. There was no good measure of dignity. So we designed sort of an ordinal scale, and it was scheduled on a validated scale called the Schedule of Affective Disorders and Schizophrenia. And it just is a way of being able to grade what is your sense of dignity and to rank it, from completely intact to utterly fractured. It's my sense of dignity is lost virtually. Think about it constantly. And this was done again in palliative care. There were over 200 people who were enrolled in this study. And what do we see? In half of the group, they said, no, it's not a problem. Well, even that is interesting because it says that in the work that we do, at least every other patient, and again, perhaps more, perhaps a little less, but the data says that it's not atypical in the patients that we see who are in palliative care to, at least on occasion, have what they feel is an assault or an issue relative to their sense of dignity. And then what we found is there was a smaller portion. It turns out this is 7% of the total group had at least a moderate severity or greater. So what they're saying is that this is an issue for me. Now, a couple of things. First off, we thought, geez, why wasn't it more? I mean, these people are all near the end of life. They're all dealing with all of the issues that people near the end of life deal with. Why wouldn't we expect that more than 7% of this group might have an assault on sense of dignity? And one of the explanations that we posed in our finding is that all of these people are receiving comprehensive quality end-of-life care. If you move somebody into a place where they're no longer getting good pain management, they're no longer getting psychosocial support and spiritual supports, dignity becomes much more problematic. The other interesting thing about the study was, at least it said, patients are able to do this. They can actually give you a sense of dignity, or their sense of what their dignity is at that point in time, which was meaningful. It makes it at least something tangible. So in this study, we had all kinds of other things. We had measured pain, anxiety, nausea, depression, appetite, anything that we thought might be an important driver of dignity experience, we try to include. Although, of course, and Francisco knows well, when you're designing a protocol, you have to be aware of protocol burden. And so there are only so many things that you might be able to measure, but we tried to measure everything that we thought was critical. At the end of the day, when you do this kind of work, what it allows you to do is to do some fancy mathematical modeling. You can put all of your numbers into the computer and say, okay, what is the strongest predictor of sense of dignity? If that's my outcome variable, what is driving that? And this is using, kind of regression modeling or logistic regression, if you want to kind of dichotomize dignity intact versus not. And at the end of the day, what we found was that how patients perceive themselves to be seen, this notion of appearance, how do people view me? How do I appear? Which at the time was, again, kind of unexpected when we have all of these other variables that we were looking at. And if I think about having had sort of a research, a moment of epiphany, this was one of those moments. And the reason I describe it that way is that I always thought about palliative care having to do with, things that we were doing with the patient or for the patient. You learn certain skills, you learn how to treat certain symptoms. And yet the data was saying that if dignity is the outcome variable that we're trying to target, the thing that makes more of a difference, not that those things are unimportant, but the thing that is most predictive of dignity has to do with what goes on between our ears. How we are seeing the patient seems to be shaping their experience. Well, this is kind of wild to think that, it's not just about what I do to you or for you or with your family. It has something to do with my disposition, with my attitude towards you. So for me, this was like, well, that's very cool. That's a very interesting finding. So besides the first paper, the general paper, which was published in the Lancet, I published a separate paper in the Journal of Clinical Oncology, and called Dignity in the Eye of the Beholder. And I think it was a few years later I discovered this etching by a Dutch graphic artist named M.C. Escher. I think it's actually a compilation of two of his etchings that I found online. And it's a self-portrait. So what you can see, and I choose to call this a reflection in the eye of the health. So what do you see in the reflection? Well, you see the artist. You see a man dressed in a debonair way. He's surrounded by his books, by his paintings, by his photographs. In other words, this is an affirmation of Escher, right? This is affirming, this reflection that he sees would be affirming of his sense of self or his sense of personhood or his sense of dignity. What happens if somebody doesn't have that kind of affirming outlook? Well, then people see a problem checklist, or they see a differential diagnosis. They see a series of therapeutic challenges that you are going to try and conquer. But what they don't see is self. And as I said in my presentation yesterday, for those of you who were there, this is when patienthood eclipses personhood. And that is the source of much suffering. You might be familiar, some of you, with Eric Cassell. Eric Cassell was an American internist, and he wrote some very important seminal papers on the nature of suffering. They're still very much worthwhile reading, and they're available online. The Nature of Suffering, Eric Cassell. And he talked about suffering being the manifestation of feeling that personhood or self is under assault or under threat of disintegration. I think that's the language that he used. When you feel that you are the embodiment of your illness, that is when personhood is under assault. Just before this, I was meeting with members of the Portuguese press, and I shared this anecdote where I had met with a nurse who was a nephrology specialist. She worked with patients with kidney disorders. And and I was interviewing her for one of my books, and just to find out her outlook, her attitude towards patients and medicine. And when she was at a point of burnout professionally, she said she realized there was a problem when she would look at patients as being, in essence, kidneys on legs. And she realized this is not good. This is not good for the patient. It's not good for their family. And it's not good for me, because no patient wants to be seen as kidneys on legs. No family member wants their loved one to be seen as really just a container for an organ that is misbehaving. And she realized it was bad for her because she had lost the emotional thread of being a caregiver. So her work became very mechanical. And we know that this disconnect from the emotional dimensions of care is one of the harbingers of professional burnout. We also have data, I don't know if I will get to it later or not, but we have data that shows that when people actually avail themselves of information about personhood, when they ask about that, it actually heightens job satisfaction. So that was our first work on dignity and the first insights around dignity. I don't have any slides on the sort of a whole second stage of work, which was qualitative work. I may have something that references it, but it began to expose things about dignity that we could have never discovered. So in medicine, there tends to be a bias towards quantitative measures, quantitative outcomes. If you can't measure it, it doesn't exist, or it's not really that important. We discovered when we started we said, okay, we've treated dignity, the way you would, salami. We'll put it on the scale. How many pounds do we have? And say, okay, we got it. We understand it. But that's like saying, to understand love, we're just going to put it on the scale, 1 to 10. What defines love? Let's do some regression models. We don't need Shakespeare. We got it. We have a fix. Well, you find out that no, that's just hubris. That is and foolishness, really. So the qualitative work that we did, which really dug down into how do people understand dignity? What are the constituents? Not only just how do people quantify it, but how do they actually describe it? That was gold. And that's what really led to most of the innovations. The development of something called a patient dignity inventory is based on that model. Dignity therapy, which I'll say something about, is based on that model. Okay. So what does all of this mean? What it means is that if you're in healthcare, what goes on in your head matters. It makes a difference to the patient experience. So if you're in the room with the patient, but your head is in someplace else, preoccupied, distracted, worried. I mean, we're all human, and that really describes the human condition. It has an influence on that patient's experience. And that influence, as it turns out, is profound. So we have taken this notion of the gaze of the healthcare provider and how to understand that gaze very seriously. Because when you don't take that gaze seriously, bad things happen. Early on, we studied desire for death, and we understand that, certainly by virtue of our more recent research, not feeling acknowledged, not feeling seen, what I've called or labeled fractured personhood, is a harbinger for desire for death, suicidality. So this goes back, by the way, to one of the earliest studies that I did on desire for death in the terminally ill, and looked at what are the predictors of desire for death. At this time, we were able to say it had something to do with pain. It had something to do with syndromal depression, clinical depression, and it had something to do with perceptions of social support. So those were the things that we were able to look at pre-dignity. My career should be divided between pre versus post-dignity. It's a different era. We also looked at will to live. And these again were these are some very early studies. I think many people, when I look around this room, weren't born at the time this paper came out. This was in the Lancet 1999. We looked at will to live, and we had people measure or rate their will to live on a visual analog. Twice a day, every day, from the time they came into the hospital to the time that they could no longer give meaningful data. Now, why didn't we ask them about their desire for death twice a day, every day, from the time they came into the hospital until they could no longer give meaningful data? They would have wanted to kill us. This is why. So will to live, and again, this is probably the second funniest thing I'll say today. So it's okay to take a moment. That was funny, sort of. What you can see is that will to live, this is a piece of data in an 80-year-old woman with colorectal cancer. When she first comes into the unit, will to live is poor in that it has a high score. it immediately improves, the score's lower. And then towards their end of life, it becomes more erratic or more erratically reported. What's fantastic in this particular slide is you're able to superimpose other subjective experiences. And here you can see this juxtaposition between pain and will to live. And they do this tango. And we can't talk about causality, like maybe she has good pain control. Good pain control has spiritual outcomes. Will to live improves. Or it could be that she now has the support she needs in an inpatient palliative care unit, and so her subjective experience of pain is lessened. Either which way, what it also says, though, is that we tend to silo these things for benefit of language. We talk about, the somatic issues and the psychological and the existential. The reality is that this is the silo. I mean, the human being, the whole person, so that spiritual interventions can mitigate pain and somatic pain interventions can mitigate spiritual distress. This is now skipping ahead several decades. This was just maybe a year or two ago, a couple of years ago, talking about fractured personhood, this idea of a state of brokenness. We have found that in our patients, in palliative care, this issue of no longer feeling like I'm the person I once was, that is one of the items on this measure that we call the patient dignity inventory. And the only reason we knew to ask about it is because it came out of our qualitative work. That was one of the items that patients said, you want to know what undermines my dignity? Not feeling like me anymore. That's what undermines my sense of dignity. So this feeling of being broken, not feeling like they're the person that they used to be or want to be or need to be or are still trying to be. So in this paper, what we did is to say, is this just a dynamic near end of life? Or is this part of the dynamic of suicidality across the life cycle? In other words, if we're trying to understand why do people no longer want to be alive, is it the case that you just move near end of life and suddenly, oh, not feeling like me, that might be why I want this final time to end? Or is it the case that if we're going to understand suicidality in its entirety, that we need to understand this dynamic of fractured personhood and dignity? We also just recently, a few years ago, published a paper in the Canadian Journal of Psychiatry in which we showed that suicidality was directly linked to measures that we were able to obtain on the patient dignity inventory. So here we have an instrument that we used developed in palliative care. We now take it to otherwise healthy patients who are in an inpatient psychiatric facility. And what do we find? They say there's an association between suicidality and lost dignity. So it's not that dying has a monopoly on dignity. Dignity is really about, being alive, being human, and being needing to be seen and being affirmed. Currently, and it's very interesting, doing a study of this issue where we're going into inpatient psychiatric facilities and talking to people who are suicidal or have attempted suicide. And these issues, they hit you in the face. They're just so profound. It's like we were talking about in one of our conversations, we tend to very quickly try to jump to labels. Oh, this person is depressed. This person has a PTSD. But when you dive into, tell me the story that got you here. Connect the dots between you being here and wanting to be dead. And this issue around fractured personhood, I'm not the person that I want to be. I'm broken, I'm worthless. And that's not out of a psychotic position, but it's a position of feeling I don't matter anymore, is being profound. So in some ways, what this comes to, I talk too much. Too much, too long. But no, how long have I been speaking now? I've been speaking for 45 minutes? 40. That's terrible. That's too long. we'll try and bring this to a reasonable close within 25 minutes or so. In some ways, this sort of encapsulates the essence of, I think, what I've been trying to say, which is medicine is very transactional. I mean, objectively, from the outside, we try and understand physiology and pathophysiology, and we do try and come up with a diagnosis and differential diagnosis and problem checklist and a series of therapeutic opportunities. At the center of it all remains a patient. That hasn't changed, even though medicine has changed. That dynamic hasn't changed. And patients, in spite of how transactional medicine has become, patients still want and need to be seen. It's the title of a paper that I wrote many years ago was called "The Secret is Out. Patients are people with feelings that matter." There. Even if I stopped right now, I'd say, okay, that's a good note to end on, but I'm not going to stop quite yet. There's still some more things. Okay, maybe I'll go through this quickly, just because all of my articles, by the way, are open access. They're all in the public domain, so you can get any of them. You can go to dignityandcare.ca, and we try and house all of the papers. I think in most instances, you can get a PDF. So years ago, I published this paper in the British Medical Journal. It's called The ABCDs of Dignity Conserving Care. It's sort of borrowed from the idea of the ABCs of critical care. I mean, in medicine, if you come across somebody who's unconscious, nobody is absolved from knowing clear an airway, make sure they're breathing, circulation. But when it comes to the humanities of care, we say, well, there are no kind of core efficiencies. Just do your best, try and be a nice person. Sometimes that works out, and sometimes it doesn't work out. I say, they say, trust your gut. And I said, not everybody has a talented gut. So the ABCDs of dignity conserving care are to say, if you are in a position to have patient contact, this is kind of an acronym that can give you a way of practicing humane dignity conserving care. A is for attitude. I've already said that. Your disposition, your outlook. I'm not trying to pontificate. That is based on the data. B is for behavior. Do you meet someone's gaze? Do you not meet someone's gaze? Do you sit? Do you stand? I did include this slide. I love this slide. I didn't do this study. This is a randomized controlled trial of sitting versus standing. First visit, orthopedic surgeon, post-op visit. They walk to the room, they take a chit off of the door that says sit or stand. The rest of the routine is identical. What happens? What happens is that if they sit, the perception of the patient in terms of the amount of time that they were actually there at the bedside is magnified 5-fold. Versus a much lesser distortion in time if they are standing. The level of satisfaction, 95% versus somewhere between 40 to 60%. So if you say, well, this sounds very touchy-feely, this is very soft, this is very powerful data. I mean, and why is it so powerful? Because when you sit, you are giving the message, I'm here. I'm not running away. I'm paying attention. I mean, you can still be distracted, but it's a little bit harder to be distracted when you're actually sitting in a chair at the patient's bedside. C is for compassion. Compassion is the idea of understanding the suffering of another person, and I underscore that, and trying to respond to it. So you cannot respond to human suffering in the absence of understanding who this person is. And that's why I underscore person. It's understanding the suffering of another person and your attempt to mitigate it. Shane Sinclair was one of my former post-docs, not post-op, thinking too much about surgery, post-docs, and he's now become an expert on compassion. It has published extensively. If you don't know of him, Shane Sinclair. And what he says is that compassion is a verb. Okay, compassion is a verb. It implicates action. So there's the And this idea of understanding a person, people give lots of lip service to this idea of person-centered care. I say, unless you understand something about the person, you are not doing person-centered care. You might be doing kind care or attentive care or friendly care, but unless you understand something of who this person is, you can't do person-centered care. This was an interesting story that I'm not going to tell you, but we'll move on to the D of dignity conserving care. And D is for dialogue, conversations. And of course, there are many different kinds of conversations that we can use to try and elicit personhood. It's all about putting personhood on the radar. Okay, back to Dame Cicely. You matter because you are you, and you matter to the end of your life. We'll do all that we can to help you die peacefully, but also to help you live until you die. I've shown you this picture. What I didn't tell you about this picture is that, and this was taken the very first time that I visited her at St. Christopher's Hospice at King's College. I was so nervous to see her because she was this giant, and I thought, oh my God, she also had this reputation of not suffering fools gladly. So she was a serious person who I thought was going to ask me serious questions about things that I'd been writing, and I thought, I better study what I wrote just to remember what, so I'll have the answer. Dame Cicely, I'm not even sure she knew who I was. She asked me nothing about my work. The only thing she asked me, and in some ways she reminds me a little bit of Dr. Nunes, she asked me, not if I wanted a port, she asked me if I wanted a sherry. And that's her liquor cabinet. These are empty sherry glasses. And it's the only reason that we're looking as happy in this photograph is because, now this was 10 o'clock in the morning, and I was about, after this, to have to go and give grand rounds to everybody at King's College. But when Dame Cicely says, do you want a sherry? Like with Dr. Nunes, there's only one answer. Yes, of course. Of course I want a sherry. So let me try and take maybe 10 more minutes or so. We have time, don't worry, talk forever, right? I know of some people here who have to catch a bus back to Lisbon. They said by 7 o'clock, they have to be on that bus. And I said, if I'm talking at 7 o'clock, somebody put me away, just take me away. So let me, the last thing I want to talk about is something I mentioned yesterday that I call intensive caring. So Dame Cicely said, you matter because you are you and you matter to the end of your life. But what that got me thinking about is, well, how do you invoke that kind of care? I mean, it's one thing to say you matter because you are you and you matter to the end of your life, but it's quite another to say, okay, how do I provide care to somebody who feels that they don't matter, who feels hopeless, who feels worthless, and that there is no point in staying afloat, if we go back to that first slide. So when somebody is in dire straits physically, we give them intensive care, right? But what if the nature of their distress is psychosocial or spiritual or existential? That's where the idea of, well, we'll give them intensive caring. And so the rest of the talk, in about 10 minutes, I'll just kind of go through the 5 core tenets of intensive caring. And again, it probably moved through more quickly than is reasonable, but the article is in the public domain and available, and I think it's been translated into multiple languages. There's also an infographic that has been published in multiple languages. I'll have to check if is there a Portuguese? There's a Portuguese infographic as well. So what is the first tenet of intensive caring? The first tenet of intensive caring is, I called it in the article, non-abandonment. Over the years, and it's only been a few years, I tend to call that showing up. Showing up for your patient. This person is it's good judgment. It's enough. It's enough. You've heard enough. A pleasure. So the dynamics of abandonment in medicine are really about avoiding feelings of helplessness and impotence. Why do we abandon or withdraw from our patients? Because we feel useless. You know, we feel, when you feel you have nothing to offer, or that being there is going to make you feel useless, that, you know, you're there empty-handed, then the temptation is to not show up at all. And certainly in the olden days when I was training in medicine, this was not an atypical thing. I mean, patients who were dying or were not curable, I mean, we would do rounds on the ward. They would be what, you know, called non-teaching. You know, we didn't go and do rounds on them. The staff person, if they had time, would go and see them at the end, or they might take us. But this was the lowest priority because they're beyond the reach of cure. So the first tenet is to say, show up, get over yourself, be there, and be present with the patient. And by the way, Dame Cicely also said, suffering is only intolerable when no one cares. So interesting. I also referenced another study yesterday. It sounds like I'm trying to speed things up, but I keep on thinking of other things. There's a study of young cancer patients with cancer, young people, and they looked at the greatest predictors of suicidality. And they reported that the strength of the relationship with the care provider was the most predictive variable in terms of suicide outcome. So if showing up is sounding touchy-feely, kind of lame, it's not very powerful, it makes the difference between patients wanting to live and patients wanting to die. So that's the first tenet, is show up, non-abandonment. The second one is taking an interest in the patient as a person. And of course, that's based on empathy, respect, connectedness, affirming their worth in terms of who they were, try to accomplish. What are ways of taking an interest in the person? We have done many things over the course of my career to try and put personhood on the radar. Dignity therapy is just one of those ways. It's not the only way, and it's not necessarily even the best way, because it takes some resources and training. But dignity therapy is based, again, it comes entirely out of the qualitative work and the qualitative model in which patients told us, one of the things that affronts my sense of dignity is that with death, there will be no ripple effect. I mean, what difference will my life have made in the world and in the lives of people who carry on after I'm gone? So dignity therapy was developed to give people an opportunity to create a legacy. And we have trained people for decades now. And in Portugal, we held training opportunities here. And now there are scores of studies, and there's I think about 14 systematic reviews. So it is the most studied psychosocial intervention in palliative care. I will take a moment to tell this story just because it's illustrative and poignant. One of the things that's helpful as a clinician, and one of the things that makes you feel less helpless, is that if you can show up with a tool that works. So if you don't have a tool that works, then you feel empty-handed. So I was referred a young woman for dignity therapy. She had heard about it. She had gone to her social worker. Through the social worker, she found out about this. She was a young mother, had a young child, had a terrible tumor. She had a stage 4 breast cancer. She was dying, young marriage, and she knew that this was something that she wanted to do. So she came in to see me, and we did dignity therapy. Well, what did that mean? She wanted to talk about a little bit about her life, a little bit about formative experiences, about her values, about things that she hoped might help shape or influence this young child that she knew would not, grow up and have a real vivid memory of her mother because she was just too young. She was able to give explicit permission to her husband to find a new love partner, with the proviso that whoever he found would love their daughter the way a mother is meant to love a daughter. Wonderful. Now you think, how would you feel entering into that conversation with somebody under normal circumstances? Well, you leave feeling completely depleted, feeling like, oh, God, I mean, I need to go with Dr. Nunes and have more port. Like I need to clear my head. But when you go into a room with a person like this, with exactly the right tool, I mean, I knew as we were doing this, because she used every moment to create this document that she wanted her daughter to have. Um, I felt very uplifted that this was, I mean, as a clinician, this was being extremely effective because you had the right tool to try and you can't eliminate that suffering, but you can be responsive in a way that mattered, that made a difference. The other thing, of course, is that not everybody can get dignity therapy or wants dignity therapy or needs dignity therapy, but every patient needs to have their dignity affirmed, which is about acknowledging personhood. So this question, the patient dignity question, is what should I need? What should I know about you as a person to help me take the best care of you that I can? It seems like a silly thing to try and study, but we have studied it, and now there are thousands of patients that have been reported in the literature who have been engaged in studies of the patient dignity question, and it's now translated into, I think, over 20 languages at this point, including Portuguese. We go to the bedside of the patient. We have a conversation that goes something like, we know lots about you physically, about your medical circumstance, but we really don't know who you are as a human being. So the patient dignity, what would you want us to know about you as a person? And that's the important, as a person, in order to take the best care of you that we can. We have a short conversation, 5 minutes, 10 minutes. 10 is about average, 10 to 15. And it's a very focused conversation about personhood. It might be about values. It might be about relationships. Another way of putting it is, for any person walking into this room, how is it that you would want to be seen? And clearly, it wouldn't be as kidneys on legs. At least it would be something else. So we then go and we summarize that. There are now some people who are playing with AI applications, which I think would be really interesting to use AI, not for the purposes of the interview, but for the purposes of the summary. We have done the summaries, and it does, AI notwithstanding, in 10 minutes, you can have a nice summary of a few paragraphs or a couple of paragraphs that we then go back to the patient to, 1, read, 2, give them a chance to make any editorial changes. And then 3, and this is the litmus test, do you want this on your chart? And I've never heard of an instance where the patient said, that describes me, but no, I don't want anybody to see me that way. Everybody says, yes, this should be on my chart. And also families can do this by proxy. So, and we've recently published some papers in intensive care where families have done this for people. This was during COVID, and people who were unconscious or on ventilators. So this is just a bunch of numbers that said it works, they love it, it's wonderful, that it improves their dignity. Very boring numbers. I mean, they're exciting to me, but we don't have to spend a lot of time. And healthcare providers who read them also say, it's wonderful, in 90% of instances, it teaches me something I didn't know. And even though these are palliative care clinicians, in 40 to 65%, it increases things like respect and empathy, which, I mean, and this group is wired for those qualities, and yet this intervention enhances that. This was done in an intensive care unit. And there are 2 papers that have come out on this, one that is now in the Journal of Critical Care, and one that was just accepted. I just looked at the galleys this last week that will be published there. So this is a woman who is unconscious. She's in the intensive care unit, and this is her daughter named Terry. And this was a First Nations woman, if I recall. So Terry wants the healthcare team to know, and this is a verbatim from the summary. Terry wants the healthcare team to know that her mother is not any ordinary patient, but is a special woman. Since my mother was admitted, I have been struggling to find a way to share my mother's story with the staff, but my heart is so happy that this PDQ will now allow me to do so. I hope the staff read my mother's story and appreciate the life she lived. And this is just on the 35 or so people who did it. And again, everybody is scoring as high as possible in terms of it was meaningful, it should be offered to other patients, and so on. So these are just, oh yes, they're Portuguese. This is just some of the languages in which it's been translated. Oh, do I have time to, we're still okay? You're not exhausted. No. Well, me. No, no, I'm fine. I'm fine. So the other thing worth saying, and again, I mentioned it yesterday in the acceptance ceremony, we take very seriously the gaze of the healthcare provider. So we have to ask ourselves, what informs that gaze? So when you think about you have somebody in a difficult situation, what do you offer them? Well, intuitively, we usually use the golden rule. We say, okay, if this was me, or if this was somebody in my family, what would I want done? In other words, doing unto others as you would want done unto yourself. Um, so that is the golden rule, and an important way to kind of begin to think about, well, how might I respond in a way that is appropriate and empathic? The problem is that it means that we do have to impose this external standard. We become the measure, the barometer of what this person might need. And that can lead to therapeutic nihilism in some instances. Like, what if I was that old? What if I was that disabled? What if I was that marginalized? And so on and so forth. And what it can lead to then is advice. I mean, that comes out of a place of beneficence, I believe, but it can lead to advice that's based on trying to guide the patient along a path that you yourself would find acceptable, or avoiding a path that you yourself would find horrifying and untenable. Well, the problem is, what if your vision and the patient's vision are different? What if your sense of quality of life is very different from that individual's? So it can lead to discordance in goals of care, and that is problematic, which is why I've written about the platinum rule. And there are a couple of articles, one in the Journal of Palliative Medicine, one in JAMA Neurology, doing unto patients as they would want done unto themselves. There are lots of nuances that we could talk about, but essentially it says we have to understand and appreciate the patient's gaze. I mean, if we're going to give priority to a lens, it shouldn't be the one in our head. It should be the one in their head. So this is a photograph of my sister, Ellen. Ellen was born with cerebral palsy. She died about just over 10 years ago at the age of 55. This was the article that was written in JAMA Neurology. Several years before Ellen died, with cerebral palsy, she had all kinds of, physical problems, kyphosis, scoliosis, terrible lung capacity, couldn't blow out birthday candles if her life depended on it. But she enjoyed her birthdays, that I can tell you. So several years before she died, she was now again in hospital, and this time in intensive care. And things were looking serious because the internist who was pacing about the ward was trying to figure out, what am I going to do here? And what he was trying to figure out is, does she need to be intubated? Does she need a breathing tube? And he came up to me to ask me the only question that he was going to ask about personhood. So he had looked at her, he looked at her bent spine, he looked at her dropping blood gases, and the question he asked me was, does she read magazines? And I thought, that's a ridiculous question. Like, don't you, this is a very serious situation. Don't you see my sister is really sick here? But he asked the question, does she read magazines? And at first I thought, well, that's kind of wonky. But then I realized that there was a subtext. And the subtext was, he couldn't see Ellen. He could see a woman with cerebral palsy. He could see a woman with a bent spine. He could see a woman who was in respiratory distress. But he couldn't see who she was and her life and her values and our family and all of that. So I said, yes, she can read magazines, but only when she's in between novels. Yeah. So the platinum rule, change the perspective. I mean, it wasn't that he was trying to act out of malice. He's trying to say, what would be the merciful thing to do here? unfortunately, his sense of mercy and Ellen's sense of what mattered, I mean, they were like worlds apart. Okay, so the merits of the platinum rule: always consider the patient's perspective, confront our own personal biases. So, when we talk about equity, diversity, inclusiveness, I think this is an important plank that we need to remember. And it raises the bar on person-centered care. Okay, we're almost there. I'm going to land this plane very soon. Within 5 minutes, we're landing. The next tenet of intensive caring, so we've got non-abandonment, take an interest in the person. Next, the tone of care. It's not necessarily about what you're doing or saying. It is about your tone, your demeanor. And these elements came from a study that we did of tone of care in a group of psychosocial oncology experts. So presence, empathy, judgment, being authentic, trustworthy, fully present. That is a big one, by the way, because, your phones are with you. There's lots of distraction. Being fully present matters, even sitting down, by the way. And you know that from the data. Second last, and this is perhaps the most complex, and I'm going to spend way too little time on it, but holding hope, knowing what's still possible. The fact is that, for certainly, I mean, we've got some folks here from Lisbon who work in palliative care. You know what's possible when you show up. What's possible is to manage symptoms, to make people more comfortable, to find out who they are as people, for their families, to engage in conversations, to reminisce, if nothing else, to prepare one another for a time when you will no longer be in each other's lives. So, as I say, that's just a very high overview gloss of this tenet that I call holding hope, or knowing what's possible. And then the last one is therapeutic humility. We are so used to, in medicine, feeling like, the reason that we can do our work is we examine, we diagnose, we fix. Therapeutic humility says, in the absence of being able to fix, I'm still going to show up. I'm going to let go of the need to fix. I'm going to trust in the process and just kind of honor the patient and their expertise, and tolerate clinical ambiguity. So I said in the paper, therapeutic humility sees notions of fixing yield to commitments to understand the nature of the patient's suffering while creating a safe space to bear witness, to validate, and to comfort always. So it's a shift in medical paradigm. We go from examine, diagnose, fix to intensive caring. Who is this person? What is the nature of their suffering? And being present, showing up. This is just how the article ends. It's been more than 50 years. She shared this wisdom. Decades later, when medicine's reach to fix exceeds its grasp, the time to consider the role of intensive caring is now. And this is just a photograph that was taken of me doing the white coat ceremony at our medical school. This man wearing the orange bow tie is the Dean of Medicine. And he asked me to give the white coat ceremony to the incoming medical students, in which I talked about many of these kinds of ideas, including the idea that I shared yesterday, which perhaps is worthwhile closing with, which is patients won't care what you know until they know that you care. So now it's time to take a break. Everybody can stretch, and we can now begin a conversation. Thank you. So I am open for, this is a time for conversation. Yes, please.
Yes, some people who are online.
Yes, very much so.
Hi, Professor. Thank you so much for this inspiring class, first of all. Let me introduce myself. My name is Helena Pereira. I'm a psychologist. And last year, I concluded my PhD in palliative care at this university that you now are part of it.
I am. And I have the ring to show it.
Proof, you
Yes.
precious. And my the subject of my PhD, it was related with wish to us and death. And I have a lot of questions to you about this topic, but I will resume in 3 questions.
Very good.
Question that I would like to ask.
I have an older mind than you, so I might Yes, okay. Very good.
Next question. It's just a curiosity that I have. If I understand, if I understood correctly, you told us that in Canada, assisted suicide it's possible, but it's euthanasia that is practiced.
Yes.
I would like to know is the motive of this, or what do you think that why this happens? It's just a curiosity. And then related with wish to hasten death, as you may know, in Netherlands, that it's the country in this topic that everything happens. Medical assisted in dying, it's possible for people that have mental disorders. And I would like to ask your perception about this and the relation with dignity. As psychologists and psychiatrists and psys that we have, I would like to know.
We have to have a whole seminar, you and I, just together. This is these are great questions and important topics. Yes, and the third?
And the third, it's related with intolerable suffering or relieved suffering. What do you think about dignity therapy can be related with the minimize the intolerant suffering that is the topic that's presented in all legislations of the medical assisted in dying, and I would like to know what you think about the possible relation with the this topic.
Oh, fantastic! These are excellent questions, and I'm glad that I wrote them down. Okay, so we'll start with the first one. Why is it that Canada's program has essentially turned into a euthanasia program? And to be truthful, I don't know that I have a good answer to it. I can just say very authoritatively, I mean, the number of cases, I don't know that I've ever come across a case where somebody was prescribed a lethal drug that they could use at a time of their choosing. It is essentially a euthanasia program. Now, I mean, my imagination is good, as is yours, I'm sure. Why might that be? Well, you know, people might feel that there's a certain comfort in somebody else kind of taking authority, taking charge, perhaps exercising agency at a time when they themselves find it difficult to do that. So for all of those reasons, I think that that is how the program has developed in that way. As I was saying before, being given a lethal prescription keeps open the dynamic of ambivalence. And we know suicidality is associated with ambivalence. So that does not play out with a euthanasia intervention. Yes, occasionally the family will show up, the doctor will show up, the team will show up, and the patient, and part of the protocol is they have to be asked, even before it is about to be done, are you still wanting us to go forward with this? Yes, I have heard of instances where people say, you know what, we're not going to do this. But it's not as easy, you know, because you're creating certain expectations for everybody around you that this is the timing that you have chosen. So is there some deeper explanation? You know, there may be, but that's the one that, and maybe the other thing is that it's been very professionalized. You know, so it's something that, I mean, there is now an organization called the Canadian Organization of MAID Assessors and Providers. CAMMAP is the way the acronym is pronounced. And the people who have formed it are very much people who have been very active in trying to promote the legislation and to promote the expansion of legislation. So CAMMAP consists primarily of doctors, small number of nurse practitioners, because the legislation also allows them to be involved in administering a lethal agent. So that's the first question. Oh, the second question is a loaded question. mental illness. So right now, the Carter decision was a decision of the Supreme Court. It happened in 2016 when actually the decision for Carter, I think, was 2015, 2016. The Canadian government came up with legislation that then said certain elements of the criminal code are to be changed. No longer homicide. Under these conditions, somebody can get a hastened death. But it did not include, at the time, mental illness. So what happened? MAID is driven by concerns around autonomy, and autonomy behaves like helium. It occupies whatever space and as much space as you give it. So in 2016, the legislation said people who have a reasonably foreseeable death can access this. Well, immediately you can see what might happen from a legal vantage point, which is people to say, well, that violates my Charter of Rights. I don't have a reasonably foreseeable death, but I'm suffering. Why shouldn't I have access? A court in Quebec agreed. The federal government didn't contest that decision. And so in 2021, new legislation came into effect, said there's no longer just track 1, which is reasonably foreseeable death. There's now track 2, which says you don't have to have something that is causing your death. If you have irremediable, unbearable suffering, you still have access to medical assistance in dying. But that doesn't include mental disorder as the sole underlying medical condition. On, I think it was 3 different occasions, the government said, well, you know what? We're going to decide on that later. And so they said, eventually we're going to allow it. And when the sunset clause lifts, it'll now be allowed. In March of 2027, in Canada, the sunset clause on mental illness is supposed to lift. In other words, if nothing changes, if nobody contests it, if nobody argues it, Canada will then be allowed to provide medical assistance in dying for people whose sole underlying medical condition is a mental disorder. What are my thoughts on that? Well, I've got many thoughts. 2 primary thoughts about it are the reason I think this is a very bad idea are twofold. One is the legislation says to qualify, you have to have grievous and irremediable suffering. The truth is, when it comes to serious mental illness, psychiatrists have no way of predicting therapeutic outcome. There have been studies that show the ability to predict recovery in people who have non-responsive depressions is 47%, less than flipping a coin. So this is the first stumbling block. Unless we can come up with a crystal ball, we can't say that these are people who have grievous and irremediable suffering. The second problem that we run into is how do you differentiate suicidality in patients with serious mental disorder from a rational, bona fide request for medical assistance in dying? And again, this is not Harvey Chochinov's opinion. This is from the International Association of Suicide Prevention, the Canadian Association of Suicide Prevention, the American Psychiatric Association. They've all said there is no difference. There is no difference. The only time they've been able to say there is a difference when it comes to medical assistance in dying and suicidality is they say if the person is dying. So in Oregon, for example, you have to have a life expectancy of less than 6 months. They can say, okay, if you've made a request for a hastened death and you have less than 6 months, we don't treat that the same way we would suicidality. But patients with mental disorders are not actively dying. The last thing is, oh my God, this is like a whole other lecture. How do we deal with suffering, and what about dignity therapy, and does that influence outcomes for MAID? There haven't been controlled randomized trials of dignity therapy specifically for patients who are intent on medical assistance in dying. I have seen patients who have requested it, who have come to me for dignity therapy. Some people have continued down the path of medical assistance in dying. I mean, very happy with their outcome and being able to create a legacy, but it didn't stop them from seeking out medical assistance in dying. And I've had others who said, you know, I'm gonna forestall this. I want to engage in this kind of legacy activity, and died of a natural death. So, and that's just scratching the surface of some of the things we could say, because it's your bigger question is, how do we deal with irremediable suffering? That's the bigger question. I hope I've tried to kind of broach that a little bit by introducing some of these concepts around intensive caring. Thank you for the questions. Yes, and we'll get a microphone.
Hi, I have a much simpler question.
Oh,
I'm a urologist, I'm not a psychologist or a psychiatrist, but I was very let down when I started working. I just finished residency because we deal a lot with death and palliative care patients, and we have no competence. We have lessons during med school that teach us about these concepts, but we are too young to understand them because we have no patients at this time. And then we do have patients and we run from them, just like you asked. We call the patient care colleagues and they come fast because we don't know how to deal with this. And as you are part of our university now, how do I also, because I feel like this is also my responsibility since I also teach here, how do we pass down the importance of giving dignity, since our clinicians, I feel, we only ask for CTs and MRIs, and we are in the computers, and our congresses are about AI and not only cancer patients, just older patients. We have an older population, and we deal so much with unsolvable problems. How do we teach the next clinicians generations to talk more? I don't know how to empower them about, because a lot of doctors don't have any skills on being human, honestly. So how do I pass this down, because we only are objective and I have no competence in this area.
Oh, these are fantastic. You said this was going to be a simple question. Let's move on to a hard question. No, it's a wonderful question, and it's not simple. You know, this idea, I have no competency to be human. Well, I would say, I mean, all of us, I think, have capacity to be human. I mean, we are human. I mean, when we set aside our white coats in our everyday experiences and everyday encounters, we are dealing with other human beings, and we're dealing with them in a way that is not so transactional as you are in medicine when you're ordering the CAT scans and the MRIs and thinking about AI applications for your charting and so on and so forth. But you're in relationships with people, and you understand in relationships with people some of the complexities of emotional chemistry. It's a different kind of chemistry, but it's still real, and you can see that it makes all the difference in every other relationship. So this is trying to harness some of those skills and try and take some of those skills, and understanding that you don't have to separate them out from who you are as a healthcare provider to be an effective clinician. In fact, if you can somehow try and bring that into your work, you know, it transforms you from being a what I've called a human body mechanic to a healer. I mean, a human body mechanic, you know, it's like you're working with cars. There's a part that needs to be replaced. There's a dent in the fender. You know, we just kind of pull something out, we put something in, and it's done. Very transactional. But people aren't made of steel and aluminum, you know, like by that article. The secret is out, patients are people with feelings that matter. So you need to begin by somehow trying to find a way of bringing that, who you are back into those encounters. And again, there is no neutral here, by the way. I mean, because you might say, you know what? That's ridiculous. I'm going to go into I'm just going to keep on being who I am and doing things the way that I do. Well, and again, I mean, it sounds very poetic when I say metaphorically, patients are looking for a reflection in your eye. The truth is, I mean, if all they see is somebody who is ordering the next CT scan and the MRI and thinking about AI applications, they feel unseen. Now, you might say, well, okay, maybe somebody else will look after that. Or does that really make a difference? Does it matter? So there are two ways of kind of looking at the ways in which it matters. One is that, I mean, if you can begin to even, I mean, it's sort of a way of being in the world. I mean, if you can begin to think about the fact that, who you are as a person, if that can also be incorporated to who you are as a care provider, it changes that chemistry. What difference does it make? Well, patients are going to be happier. Why? Because they feel acknowledged, they feel seen. You're not just the person who's giving them a requisition for a CT scan and then, running out of the room because you just don't have any time or you really don't feel that you have the skills. And I would say, well, if you have the skills to be in a relationship, then you have certain innate human qualities that you can invoke to improve that emotional chemistry. So patients will be happier. Families will be happier. I mean, families, the things that affect patient dignity also affect families. If the thing that families hate most is if their loved one is treated just as an organ or a body fluid that has gone wonky. They said, you're treating, this is my mother, or this is my partner, or this is my child. And if you don't get that part right, families are going to be pissed at you. I don't know if there's a good translation in Portuguese. And as I said, also what happens, I mean, in terms of kind of, your own development, and it's interesting, as a young person, you said some of these things didn't really resonate. And now that you're with patients, they suddenly do resonate. And you think, no, I need to know this stuff. So when you get involved, or at least take notice of those things, it changes your own satisfaction. I remember for one of the books I was writing, I interviewed a medical oncologist. I think he was a breast surgeon, or no, breast oncologist. And I asked him about, so how does he treat breast cancer? He closed his eyes, he threw his head back, and he just rattled off a bunch of drugs. He said, a monkey can be trained to do this. I mean, obviously, I think it takes more than a monkey. It sounds very complex to me. But what he was saying is, it's robotic, it's formative, it's a protocol. He said, but connecting with the patient, getting the patient through that, he said, that's the skill. And that's where he felt pride. So those are all the positive sides of the ledger as to why you might say, maybe I should think about that. What are the negative sides of the ledger? What happens if you don't do this? You say, you know what? I'm perfectly happy the way I am now. Why should I change things? Well, the negative side of the ledger is patients aren't going to trust you as much. There's going to be greater discordance in goals of care because the things that they want, they're not necessarily going to tell you, and the things that you want, they're not necessarily going to want it. They're going to need. So they're not going to be as trusting. There's discordance in goals of care. You're going to spend your career feeling chased by patients and families because they can never get you to sit down and to talk to them about the things that are on their mind. And one of the people I interviewed in my book was a very prominent neurosurgeon. This guy brought Gamma Knife into Canada, a very eminent neurosurgeon, as busy as anybody else. And so I said, Mike, how do you handle this? He said, I sit down with families and patients, and I answer every single question until there are no more questions. I said, that's impossible. You are one of the busiest neurosurgeons in the city. How do you possibly do that? He said, well, when I do that, they don't chase me for the rest of the time. He says, they're prepared for all of the things that might happen. He says, my other colleagues, they're running into the OR. He says, they'll spend 8 hours in a complex neurosurgical suite. Spending a half hour with a patient and family is torture because they just feel so overwhelmed by all of these issues. So again, that's on the negative side of the ledger. And the last thing is the chances of you having a complaint levied against you or you being sued isn't because you made a medical mistake. It's because people felt you didn't treat them right. Again, this is not me trying to pontificate or trying to say what you should do or want to do. But if you want to avoid getting into trouble with your patients and families, as one of my, and I've quoted him many times, one of my colleagues, he was the head of our palliative care program for many years. He said, patients and families will forgive you almost anything. They will not forgive you lack of kindness. So those are some of the reasons why you might want to think about, how does this implicate me in my practice? Not a simple question, by the way, but a beautiful one.
Hi, Maya Furlan from the University of Coimbra. What you mentioned, how families don't want their loved ones to be treated as bodies. So my question builds up on this. And so I'm more and more interested in what happens around the moment of death and just moments after the death, because one of the results from my PhD studies showed that those family members that were present at the moment of death have higher chances of looking for formal bereavement support.
Higher chances of looking for formal bereavement, okay.
And there might be very different explanations. There might be closeness with the service, and so you reach out more, but it also might be that they were not prepared for what happens at the moment of death and can be very intense experience. But I was thinking whether you've ever kind of extended the dignity model a little beyond that, because that's kind of a no man's land. You know, I usually say that death is an end point for a healthcare system, but for a family member, it's just a transition. We still have a body there for some hours, and many families will be there present. So I was wondering what happens with the dignity model in that space, if it was ever extended to.
Yeah, very much so. And again, wonderful question. I'm working with a couple of colleagues. We've been working with a concept that I've been trying to develop called liminal personhood. You know, where do we locate personhood in these times of transition? And making the case, because personhood in the literature, and we've got an expert on bioethics, personhood oftentimes is based on qualities or functionalities. And so when those functionalities diminish, some people argue, well, you know, that is a human being, but is personhood maintained? This idea of liminal personhood is looking at the fact that, you know, this person, there's still moral accountability for how we are towards those individuals, whether they are conscious or no longer conscious or no longer alive. You know, it's why why is it even, you know, across, you know, millennia, there is a certain deference that is given and paid to bodies. You could say, well, why do that? It's just an inert object. It's no different than the chair you're sitting on. No, there's still a quality about who that individual was. This is the container for who that. So this idea of liminality, I think, is something that we're trying to explore. We submitted it to one journal, got back terrible reviews. I said, no, you have to do more work. So we're meeting and we're going to talk more and see where that evolves. But your point about what about things like dignity therapy or extending some of these things? Actually, the gentleman that I introduced yesterday, Miguel Julio, who's a physician, a colleague, is one of the people who has been doing some of that work. He's published some of the seminal papers that have said, well, what if the patient can no longer speak on their own behalf? Or what if the patient is no longer alive? So, for example, as a bereavement intervention, could we not interview families and say the same kind of interview, but it would be by proxy. So who is this person who has just died? What are their values that they espoused? What are the key pieces of wisdom that they would want shared with their family? You know, what is their hopes, wishes, or dreams that they would want their family members to recognize or abide by? And you might say, well, how does that help the patient? Well, I mean, this is for the living. So as a bereavement intervention, I mean, we know that one of the psychological challenges of bereavement is it's ubiquitous. It's hard to find a place to contain it. I mean, this is why planning a funeral, this is why going to a cemetery, these things are meaningful because they give form to your grief as opposed to it being kind of nebulous and vague. So could this be a bereavement intervention? We've done a little bit of work on that. We have, in one of my earliest studies on dignity therapy, we actually interviewed, I think it was 60 of the 100 patients who participated. We interviewed the family members. And I mean, and we found out from the family members, first off, that they said this intervention was as helpful for their loved one as anything else that was done during the course of their palliative care. But they also said that it was helpful and meaningful in terms of their own grief and their own bereavement process. So I think there's a lot to be done, even amongst patients, for whatever reason, be they a child, be they an adult, be they have cognitive decline, be they no longer be here, who no longer have a voice. Yeah. You've got to catch your bus to Lisbon. Okay, get in this question.
So thank you so much for your presentation. I would like to ask you if you have some tips to us to tell us how to help a fragmented person to see how they seen themselves back in the days, because sometimes that question you told us about, we often do that at our practice, and sometimes patients have difficult to answer it. And
the question of no longer feeling like the person,
no, what we should know, the dignity care.
Okay, very good. So a couple of things. One is send me an email. I will send you an article. There was an article that I wrote, although you can always find it. I think it was called Revisiting the Patient Dignity Inventory. And it was in the Journal of Palliative Medicine. Because a number of people, you know, when I've spoken around the world, say, you know, I tried that question. It really doesn't work. And I said, well, what happened? They said, well, we asked the question and they seemed confused or they didn't know what to say. And so I'm not sure that it really works. So here's the thing. It's just a question. The order of the words are not magical. It's the idea that is important. So you need to then explain, well, you say you don't understand it. Well, I want to find out who you are as a human being. I mean, I know I'm your doctor. I know I've looked at all kinds of things about your body and your heart failure, your cancer. I have no idea who you are as a person. That's what I want to find out about. Now, I know that when I say that, you say, well, that doesn't sound like the patient dignity question. Patient dignity question is just meant to be the stem of a conversation. So I tell people, have that conversation. You know, and I think if you explain that, there are very few people who wouldn't understand. I mean, I remember years ago, in the very early days when I was trying this, I walked into the room of somebody. It was a gentleman. He was there with his wife. He was in the hospital. English was his second language. And I came in and I was about to say, so what do I need to know about you as a person? He looked at me like, and one of the reasons is not only difficulty understanding the question, people are taken aback by it because it doesn't seem medical. So I say, well, you're a doctor. What do you mean? Who am I as a person? You know, I said, so I'll tell you, you know what? You're right. This isn't medical. This is a different kind of conversation I want to have with you. anyways, I tried it every which way, and I thought, maybe this is a dumb idea. Like he doesn't seem to get it. At one point he said, well, you need to understand that I'm worried about how I'm going to navigate the steps when I get home. I said, well, that's very interesting. I said, but and we'll tell your doctor and the occupational therapist that you're worried about that. But that's what I want to know is, who are you? Who are you as a person? And his wife was sitting there this whole time listening, and she had the same kind of blank look. And all of a sudden her eyes lit up and she said, oh, you want to know about Manuel. He is the person who everybody in the neighborhood comes to for advice. He's in the choir. He's the person. I said, yes, this is exactly what I want to know. So the first thing I'd say is explain the question. I mean, because otherwise they're not necessarily going to understand it.
When the patient is like fragmented,
Yes.
That's...
So let's get back to that. I knew there was another thread that I had lost. So, and this gets back to I think the questions that we were talking about. Like, so what do you do about unbearable suffering? And although I know it sounds simplistic, I think what you do about unbearable suffering is intensive caring. You show up, you take an interest, you understand the potency of therapeutic tone. You hold on to hope, because people can feel very hopeless. So you are open to those possibilities of what might happen, and you bring in your humility. Now, again, what does that look like? So a couple of years ago, the Canadian government, again, was on the brink of introducing MAID for mental disorder. Back to you. They were on the brink of MAID for mental disorder. And I wrote an article that was published in a national paper saying, I don't think it's a good idea. Here's why. We can't predict irremediability. We can't tell the difference between suicidality and requests for MAID. The other thing is, I mean, one of the central plank of suicide prevention is connectedness with the patient. Anybody who has been involved in caring for people who are chronically suicidal knows that they have to have this unwavering commitment, valuing this person and who they are. So that is critical. So I wrote this article in the newspaper. A couple of days later, a young man wrote me back. And basically, he said, I am mentally ill. I am suffering. You're some big, powerful psychiatrist. Piss off. Why can't I just decide to do whatever I want to do? It's none of your business. And that was the email. So I thought, well, okay, that's interesting. So I wrote him back. This is such an interesting story. I wish I had a copy of his letter, but I've memorized parts of it. So I wrote him back, and I tried to say, okay, so how do you do intensive caring now? So I wrote him back and I said, thank you so much for writing. Thank you so much for reminding me about what suffering feels like, because that's at the center of this entire discussion. I said, I'm sorry that the decision to not make this available means that your suffering might continue. But if we open up this gate, people are going to walk through who might have changed their mind. I don't have a crystal ball. I can't tell who would and who would not get better. And that was the tone of, and again, thanking him for telling me how he felt and for taking the time to write. So I sent it off and I thought, okay, let's see what I'm not making this up. The next day, he wrote me back and he said, thank you. Your letter has given me hope. Not that my illness will get better, but that somebody out there cares. And I was shocked. I mean, it was so stunning. So because oftentimes people will say to me, you know, getting back to, we have a patient dignity inventory. It's 25 items and it asks many different questions. I think it's in Portuguese. One of the questions is no longer feeling like the person you once were, fractured personhood. And sometimes clinicians will say to me, well, thanks a lot, Harvey. What am I supposed to do with that? I mean, you know, it's not like pain or an infection. I don't have an antibiotic. I said, well, what you can do is you can listen. You know, you can be present, you can be attentive and committed. And that's how you deal, you know, so how do you deal with fractured personhood? By being with another person and trying to see something of the person. You know, it's like a, you know, who's the famous songwriter? Was it not Bob Dylan? Leonard Cohen talked about, you know, even the most, things in life have a crack in them, but that's how the light gets in. Can you be with somebody who is cracked and still see that light? I know that sounds very poetic, but we know from the data, you know, studies on suicidal patients, what is most likely to move them towards suicide completion? Don't give them follow-up. There's some studies that came out of Sweden years ago, patients with advanced malignancies. Those who weren't given follow-up, significantly higher rates of suicide. So it's a different way of looking at it. It's not fixing that fragmentation. It's saying, okay, I have to somehow find a way of being present with that.
Thank you very much. Fortunately, we in our team, we see the patient like that. And today I was telling Mafalda that sometimes I feel a bad doctor, bad physician, because I look too much at the patient and not to the disease and the problems and the clinical parts. I forget the diagnosis, and I just think about that person, that family. But I was listening to you, and that are our tools to help patients in that way, to be there, our presence, to listen to them, to think about them, to think about their life and their values. And to us as practitioners, what kind of practice, what kind of study do we have to do that right? Because it worries me, because I think we have to stop to think about the patient, to reflect, to be a human and to develop human values, and to know about a human person and anthropology. And I think we don't do that much. And this new generation, less, because they don't know how to stop, how to connect with somebody. And we are losing that kind of capabilities. So how can we, as practitioners, as palliative care doctors, train ourselves in that tools? I don't know if this is a little bit
No, it's
complicated.
all is fair here. No, it's they're wonderful questions. The questions deserve, though, more time and conversation than I can give it in a short time. But I'd say, first off, and again, this goes back to the questions that we had from our urology colleague, and it's about, I mean, you have innate human qualities that you exercise in other relationships. So you don't have to be entirely divorced. And in fact, you can't be entirely divorced from that if you're going to have a sense of who this person is. I mean, when you tap into that, you're also tapping into something of yourself. You're opening yourself up to trying to understand this complex emotional chemistry. So it means that you have to bring yourself into that conversation. The other thing is that people ask, well, so how do we create a culture of dignity conserving care? I mean, how can we start to practice in this way? And again, and this is a conversation that I had with the two of you yesterday, and so you'll hear me repeat the same thing. Hopefully, I'll be consistent. I think about three different kind of levels or layers to this. The first layer is closest to the bedside, which is, I mean, how do you interact with the patient? And again, it doesn't have to be fancy, but it does have to include personhood, transaction, or relational. One day I was walking into the washroom at work, and there was the door next to me was a clinic where an oncologist, hematologist specializing in lymphoma worked. I'm closing the door to go to the bathroom, and he's closing his door. The last thing I heard him say is, "So how was your vacation?" Lymphoma doesn't take a vacation. People do. Now, I am absolutely certain that 3 minutes later, when I came out of the bathroom, they were not talking, they're not looking through a photo album, but it's just being mindful. It's just a mindfulness to, personhood. Patients are people with feelings that matter. It can become a mantra, along with patients won't care what you know till they know that you care. These are good mantras. So the first layer is, how are you with patients? It's having that human quality. And that enhances connection, enhances trust. Everything goes better as a result of that. The second layer, though, is how do you treat each other as colleagues? Because as I was saying to your colleague sitting behind you, if you expect people to act in a way that is conserving of dignity on this side of the nursing station, but on the other side of the nursing station, the atmosphere is toxic, this isn't going to work. It's going to very quickly disintegrate. You can't, it's like love. It's hard to express love if you don't feel something of love for yourself. It's just, you can't be that way in the world. So it needs to be something that you engage in with your colleagues. You need to feel like you yourself are in an environment where you feel appreciated, you feel valued. Again, a little anecdote. Years ago, I think we were in Mexico, and it was a resort. And I noticed every time that I, as a customer, would pass by somebody working there, they put their hand on their heart and they give you a little bow. And I thought, well, that's very nice. I like that. This is where things got interesting. I was walking one day and I noticed that two people who worked in the resort, when they passed each other, they did the same thing to each other. And so the day that I checked out of the hotel, I asked to speak to the manager, and I said, "What's going on here? I mean, like this isn't by accident." And he said, "No, they have meetings as a staff, and they are taught that, I mean, yes, we want you to be this way with our customers, but to be that way with the customers, we need to be that way with each other. You need to feel respected in order to give others respect." Then the third layer, though, is the more challenging one, and that is administrative. If you're working in a hospital or in a program that doesn't value any of that, that basically punishes you because you take more time talking to the patients than your colleagues who are ordering the CT scans and the blood work, it doesn't become sustainable. So if you're thinking about a dignity conserving kind of overarching strategy, it doesn't give you all the answers, and we can't in a short time, but at least it says, these are the multiple layers that I need to be thinking about in order to invoke dignity conserving care. Oh, pleasure. Was I consistent? I said the same thing yesterday, right? Yes. Is everyone exhausted? No, no, you're not exhausted.
Hi, thank you. First of all, my name is Sergio. I'm a nurse. I'm doing my PhD in the theme of lack of meaning in life in patients with palliative care needs. I want to know your opinion about any relation that is or supposed to be between meaning in life or lack of meaning in life and dignity?
Yep.
And the second question is, have you, in your investigations, found out any predictors or risk factors to lack of dignity or lack or loss of dignity? And the third one you answered already with your presentation, that is for my practice. I have a lot of patients at some point, they say to me, I don't want to live anymore. It doesn't make sense. I'm doing anything here. And it's hard for me as a nurse sometimes to give back an answer. But with your presentation, I think I have some answers now. Thank you.
So let me start with the last one, just because, again, it takes me back to an anecdote. This was years ago. I did some training in New York City at Memorial Sloan Kettering, a very large cancer hospital. I was working in a neuro-oncology unit. I was asked to see a young man with a very complex psychiatric history, polysubstance abuse, personality disorder, and he was a very angry young man. And everybody, he was angry at everyone, and everyone was angry at him. And so I was this young psychiatrist, and I said, Harvey, you go see him, hoping to. I'm not sure they thought I would make him better, but at least to get them out of their hair. And he wanted to die. Again, this is years before there was any legal option for that. But when I first met him, he wanted me to help him die, and I said, well, that's very interesting, but I can't do that. It's not. It's not a legal option. It's not available. But I am prepared to come and see you, and for us to talk and to find out about who you are. And he said, "Oh, okay, if that's what you want to do, we can do that." So we started to meet once, twice a week, and we would do this. And he was dying of a primary brain tumor. Anyways, true to form, I mean, he was not an easy person. And he would be complaining about everything, including one day I'm with him and he's complaining about me, saying, you know, this is kind of lame and why are we doing? And so, I mean, I'm young and naive. And I said, look, you're under no obligation. I mean, if you don't want us to continue meeting, we can stop. He looked at me and he said, are you crazy? This is the only thing that's keeping me alive. So I mean, it was a wonderful lesson, you know, that connectedness, engagement, commitment, that's what we were doing. Going back to the first question, you know, connections between dignity and meaning. Again, we did our qualitative studies in which we produced what we call a model of dignity in the terminally ill. And one of those elements of the model had to do with hope, meaning, purpose. And so this model, it's not a hierarchical model because different things affect dignity for different people. But what it says that for some people, the source of loss of dignity is a sense that they are without meaning. They are without purpose. And of course, you know, it kind of harkens the work of Viktor Frankl, which I'm sure you've read and you're going to be citing frequently in your thesis. And then the second question that you asked, oh, predictors of lost dignity. Well, yes, I mean, there are many. The study that I told you about today, which the first study on dignity, the quantitative study, talked about this notion of appearance. So this idea that, you know, if you're no longer held in esteem or valued by others, that undermines sense of dignity. You could also then, in terms of looking at, well, what are predictors? If you look at the model of dignity in the terminally ill, there are three categories of sources of dignity-related distress. Some of them are illness-mediated. Some of them are social dignity inventory. And some of them are what we call the dignity-conserving repertoire, which is the psychological and spiritual kind of wiring of that individual. So I wouldn't so much call those as predictors, but that creates really kind of a therapeutic map. You know, it says these are the areas, when I think of the dignity landscape, these are the areas within that landscape that I need to be mindful of if I'm going to be providing dignity conserving care. Yeah. I feel like one of you now.
For you again.
No, not at all.
But I have another question
Thank you for coming.
about dignity therapy and logotherapy. Because we are looking to the lack of resources, but I think we need also to look to the resources we have. And of course, I will not ask you which one is best. But how can we use both in our practice when we have a patient in suffering?
Yeah, I guess we have to think of it as patients are different from each other in many ways, some profound, some more subtle. Which is to say that, I mean, not every intervention, not every approach fits everyone equally. The difference between, equality and equity. Equally is we give everybody the same thing, and that's not necessarily rational. It's like buying a pair of shoes, saying, we're going to be fair. Everybody gets size 9. Well, this makes no sense. Equity is everybody leaves the shoe store with the same likelihood that they're going to feel comfortable. So we need to think about what therapies do we offer that fit the patient. And whether it's logotherapy, dignity therapy, meaning-centered psychotherapy. Gary Roden has an approach that they've introduced called what is Gary Roden's intervention already? Don't tell him that I forgot his intervention. He'll kill me. But different approaches for different patients. The other thing, though, is before we get too caught up in, some of these interventions are more calm therapy. By the way, that's the one that Gary Roden and his group have developed called calm. I think even more fundamentally, before we start to hone in on some of these formatted, more complex psychosocial interventions, is the broader notion of how do we provide dignity and make dignity relevant for every patient. So I know that doesn't answer your question. Well, which therapy, which formatted therapy do I use? I think we need to, for our learners and for our trainees, say, even if you never learned dignity therapy, even if you have no idea what logotherapy is or calm therapy or Bill Breitbart's meaning-centered therapy, that doesn't absolve you from responsibility of understanding the importance of dignity in patient care. And what's that about? It's about bringing who you are as a human being into that room, making sure that you are able to acknowledge personhood, that patients are people with feelings that matter. That's fundamental. That's kind of core to every interaction, and not just palliative care. That applies from cradle to grave. Thank you all for being here, and thank you all for attending, and thank you for welcoming me into your faculty. Yeah.